Vaginal carcinoma originates from the epithelial lining of the vagina, a pliable muscular tube that connects the external genitalia to the cervix and uterus. In a healthy state, the vaginal epithelium renews itself cyclically, shedding old cells and replacing them with new ones. When malignant transformation occurs, a cluster of abnormal cells proliferates unchecked, forming a solid mass within the mucosal wall. Although rare, this cancer can affect women of any age, but the incidence peaks after the 6th decade of life. Because the vagina is relatively short and sits deep within the pelvis, early lesions may remain unnoticed until they enlarge enough to cause symptoms such as bleeding or a palpable lump. The most compelling causal factor for vaginal cancer is persistent infection with high-risk human papillomavirus strains, particularly HPV-16 and HPV-18. The virus inserts its DNA into the host cell's genome, disrupting normal cell cycle regulators E6 and E7 proteins. This viral hijacking prevents the tumor suppressor proteins P53 and RB from initiating apoptosis, allowing infected cells to accumulate mutations. Co-risk modifiers include chronic tobacco exposure, which introduces carcinogenic compounds that further damage DNA. Immunosuppression, for example, HIV infection or post-transplant therapy, which hampers viral clearance, and prior pelvic irradiation, which creates a field of damaged tissue prone to malignant change. Think of a garden where invasive weeds HPV spread their seeds, and a weary gardener immune system cannot pull them out, while additional pollutants smoking, radiation make the soil more fertile for weeds. Under normal conditions, vaginal epithelial cells follow a tightly regulated cycle: proliferation, differentiation, and programmed cell death apoptosis. HPV infection subverts this balance. The viral DNA integrates into the host genome, producing oncoproteins that inactivate P53 and RB. Without these checkpoints, cells bypass the G1S transition control, leading to continuous DNA replication. Over successive cycles, additional genetic insults accrue. For example, mutations in oncogenes like KRAS or loss of tumor suppressor loci, driving a clonal expansion of dysplastic cells. These cells acquire the ability to invade the basement membrane, breach the stromal barrier, and eventually metastasize via lymphatic or hematogenous routes. Clinically, this manifests as a solid, often ulcerated lesion that may bleed or erode into adjacent structures, such as the bladder or rectum. Vaginal cancer accounts for less than 1% of all gynecologic malignancies worldwide, making it one of the rarest female cancers. Incidence rises sharply after age 60, with a median age at diagnosis of approximately 68 years. Geographic variation mirrors HPV vaccination coverage, regions with low vaccine uptake. For example, parts of sub-Saharan Africa and Eastern Europe report higher rates, whereas countries with established national immunization programs, Australia, Canada, show a declining trend. In a hypothetical urban population of 100,000 women, one might observe 5 to 10 new cases per year, underscoring the disease's scarcity, but also the importance of targeted screening in high-risk cohorts. Patients often present with nonspecific, yet concerning findings. Postcoital or postmenopausal bleeding is the most frequent symptom, reflecting tumor erosion of fragile mucosa. A palpable mass may be detected during a bimanual examination, particularly if the lesion extends toward the vaginal introitus. Dyspareunia, painful intercourse, arises when the tumor interferes with the elasticity of the vaginal canal. Abnormal discharge, often serous, sanguineous, or malodorous, signals secondary infection or necrosis within the tumor. In advanced disease, urinary frequency or obstructive voiding may occur due to involvement of the urethra, while rectal symptoms, tenesmus, bleeding, suggest posterior wall invasion. Diagnostic workup begins with a thorough pelvic examination, using a speculum to visualize the lesion directly. Any suspicious area mandates a punch or excisional biopsy, which provides histopathological confirmation and determines the tumor subtype, squamous versus adenocarcinoma. Imaging modalities refine staging. Endovaginal ultrasound offers a quick assessment of lesion depth. Magnetic resonance imaging (MRI) delineates soft tissue involvement and proximity to the pelvic wall. Computed tomography (CT) scans evaluate nodal and distant metastases. And fluorine 18 FDG PET-CT can identify metabolically active disease, not apparent on conventional imaging. Pathology also includes immunohistochemical staining for P16, a surrogate marker for HPV-driven tumors, and testing for high-risk HPV DNA when indicated. Vaginal carcinoma is principally categorized into two histologic groups. Squamous cell carcinoma, SCC, is by far the most prevalent, representing 80 to 90% of cases. It originates from the stratified squamous epithelium lining the vagina and is strongly linked to high-risk HPV infection. Adenocarcinoma arises from Müllerian-derived glandular epithelium, often associated with in utero exposure to diethylstilbestrol, DES, and less frequently with HPV. Both subtypes share a similar staging system based on the FIGO, International Federation of Gynecology and Obstetrics, criteria, yet their biological behavior diverges. SCC generally responds well to radiation, whereas adenocarcinomas may be more chemoresponsive, but are less radiosensitive. Therapeutic strategy hinges on FIGO stage and tumor histology. Early stage disease, stage 1, is often curable with radical local excision, such as partial vaginectomy, striving to preserve sexual function and continence. Whenever surgical margins are uncertain, or the lesion is near critical structures, definitive radiotherapy, delivered as external beam radiation therapy, EBRT, combined with intracavitary or interstitial brachytherapy, offers organ-preserving control. Concurrent chemoradiation, typically weekly cisplatin, enhances radiosensitivity for locally advanced tumor stage 2 to 3. For metastatic or recurrent disease, systemic chemotherapy regimens, for example paclitaxel plus carboplatin, are employed, and emerging immunotherapies, PD-1, PD-L1 inhibitors, are considered in HPV-positive refractory cases. Multidisciplinary tumor boards tailor the approach balancing oncologic clearance with quality of life considerations. Primary prevention revolves around interrupting HPV transmission. Prophylactic vaccination with the non-avalent HPV vaccine covering HPV 6, 11, 16, 18, 31, 33, 45, 52, 58 before the onset of sexual activity confers greater than 90% protection against the high-risk types that drive vaginal SCC. Secondary prevention includes routine cervical cytology, pap smear, and HPV DNA testing. While these screens target the cervix, abnormal findings often prompt evaluation of the entire lower genital tract, potentially uncovering early vaginal lesions. Lifestyle modifications, cessation of smoking, safe sexual practices, condom use, limiting the number of partners, and timely treatment of immunosuppressive conditions further diminish risk. Public health campaigns that increase vaccine coverage and awareness are essential to sustain the downward trend in HPV-related malignancies. Survival outcomes are stage-dependent. For tumors confined to the vaginal epithelium stage 1, 5-year overall survival ranges from 70% to 80% with combined surgery and/or radiotherapy. Once the disease extends to the pelvic sidewall or distant organs stage 3 to 4, survival declines dramatically to 30% to 40% despite aggressive multimodal therapy. Favorable prognostic indicators include small tumor size less than 2 centimeters, lack of lymph node involvement, HPV-positive status, which paradoxically predicts better response to radiation and immunotherapy, and receipt of concurrent chemoradiation. Early detection, facilitated by vigilant symptom reporting and routine gynecologic exams, remains the most powerful lever for improving outcomes. The therapeutic landscape for HPV-associated vaginal cancer is evolving. Immune checkpoint blockade targeting PD-1, PD-L1, for example pembrolizumab, nivolumab, has demonstrated durable responses in a subset of patients with refractory disease, especially those whose tumors express high levels of PD-L1 or possess a high mutational burden. Parallel efforts are investigating therapeutic vaccines that deliver E6, E7 viral antigens to elicit a cytotoxic T cell response, effectively turning the tumor into its own vaccine. On the radiation front, image-guided intensity modulated radiation therapy, IMRT, and MRI-based adaptive brachytherapy have refined dose delivery, sparing adjacent bowel and bladder while maintaining tumor control. Early phase trials combining these immunotherapies with stereotactic body radiation therapy, SBRT, aim to harness synergistic immune activation, potentially establishing a new standard for locally advanced cases.